Welcome to the RatChat with Dr. Taylor Ratcliffe, putting the cheddar in yo chatter.
So the second case is an 11-month-old, so older than this initial kid who was 2 months. And this kid was diagnosed with gastroenteritis. And this was a home call. So this paramedics went to the home.
Okay.
And they said he has become more yellow over the past 2 days. So jaundice, he's had fever, he's had emesis, which is what initially caused that diagnosis of gastroenteritis. And today mom says he's just not acting like himself. And when the paramedics, pre-hospital providers get there, they witness a seizure.
Okay.
And so they are able to get an IO. They give some Ativan.
Okay.
And they noted that his blood sugar was also low.
Another one.
Yes.
Was it as bad as the first
Yes.
two?
It was just red low.
Oh, on our glucon.
Yeah.
Okay.
Yeah.
All right.
So he was given D10 by an IO. And when the paramedics brought him in, they said, you know what? It could just be that he's postictal, but he's barely crying to pain. Like, we put in an IO and there was nothing.
Yeah.
And again,
we know that's painful. Yeah.
That's a
big red
flag for us. On arrival, he was noted to be unresponsive. There was no eye opening. He wasn't really withdrawing to any pain. He was noted to have icteric eyes, which is that jaundice of that scleral area, so quite yellow. And he also looked quite yellow the rest of the skin.
And just real quick, like, we know newborns can get jaundice, and that's the body beginning to learn how to process things and turning on, processes. But a kid should really never be jaundiced past about a couple of weeks of life.
Yeah, probably about 2 weeks is when we start saying, hey, this jaundice is not regular. It could also be breast milk jaundice, which can occur from time to time.
Okay.
But usually by 2 weeks, we expect their liver to start processing and breaking things down. Right. So that's when we start thinking about other things.
Okay.
The exception to that rule is really premature children can still have some persistent jaundice. And
they're
usually
sneaky, very sneaky.
They're hopefully still in the NICU if that is the case, and you shouldn't be seeing those cases.
Yeah, hopefully not. Terrifying. Okay.
Yes.
All right, so minimally responsive, icteric, sick.
Possibly seizing.
Sure.
Again, was having super low sugars, has now gotten a couple of boluses of dextrose, was given Ativan for possible seizure activity. And again, because of the not responding and history of vomiting, the decision was made to intubate this kid early in the emergency department. And this kid was also noted to be pretty hypotensive, so also received crystalloids, and then was started on an epinephrine drip because his blood pressure just did not respond after a few boluses. And
is that still, our crews ask from time to time, and if read the literature seems to go around and around, but we use a lot of norepinephrine in adults, and it seems in a lot of cases to be superior. Pediatric literature seems to be different still. Kids tend to like epinephrine. Is that...
So there is, you asked the age-old question. It's like, which pressor do I choose first, right? Sure. And in the pediatric world, norepi and epi are still equally preferred as the first-choice pressor.
Okay.
So you would not be faulted. You would not go wrong with either choice. There was just a recent trial done, and there's a slight mortality benefit, non-inferiority benefit to using norepi.
Okay, got it.
Because in cases of septic shock.
Got it.
If we were thinking this is a more cardiac kid, I think epi is the right choice. But if you were thinking sepsis, norepi or epi would be the right choice.
Okay, so we wouldn't get a bad look if we picked either one in that case.
Either one, yeah.
Okay, all right.
But in the end, we just want to make sure your crews are just comfortable with whatever they're using, right? So if they're more comfortable using norepi, just start with that.
Getting the dosing right, getting the drips right, and all those things.
Absolutely.
Perfect.
Yeah. So this kid was surprisingly not acidotic like our other kid. So that's the little difference between the two, but also had some interesting lab findings. His white cells were a little elevated. His platelets were quite normal. I mean, it was a little low, but not too low. Hemoglobin was fine. The interesting thing about this second child's labs were the evidence of a state that we call shock liver. Okay, so his AST and ALT were both above our laboratory thresholds.
And those are liver enzymes.
Correct. Yeah, so above 7,500 for both of those.
Oh, wow.
Yes.
Never seen that.
Yeah.
That's crazy.
So this kid was in some degree of liver failure. Additionally, the liver does a lot of synthetic functions, and so it helps with even part of the coagulation cascade. So we look at liver function on the PT or INR as well, and this kid has had an INR of greater than 28.
So having trouble with blood clotting.
Correct.
The blood's too thin.
Too thin.
Right.
Okay, so this kid didn't have an immediate slam dunk like, oh, this is likely HLH. He doesn't meet any of those criteria that we talked about before, like 2 cell lines being down. He just had what looked like shock liver.
Sure.
To start with. And so
the differential for that is at this point is broad.
Yeah,
right?
so this could be a viral hepatitis. It could be, and not just hepatitis A, B, C, D, E. Viral hepatitis in kids can be caused by other viruses, notably things like CMV or cytomegalovirus,
Sure.
and EBV or Epstein-Barr virus, things that can, in other children, cause like a mono-like pattern. There are other GI viruses that could have just caused him to have such profound vomiting to then lead to shock liver, but it's much less common.
Maybe even some toxicities.
Exactly,
maybe.
right? So that's when we start thinking, hey, this kid needs a U-tox. Do we think this kid got into some Tylenol or something else like that could have caused this?
Okay,
there's a couple of mushrooms that can do this
Right,
too, right?
right, yeah.
So it's like the differential for shock liver, like you said, is
So you're saying that under one crowd, they still do shrooms?
Yeah,
Sometimes.
exactly.
All right, we have to remember. Think about that. Okay.
Absolutely. So this kid was treated a little bit differently. So this kid was given lactulose and rifamycin, which are things that we use in cirrhotics sometimes when we're worried about hyperammonemia.
Sure.
And we talked about how this child was on epinephrine, so a central line was placed. His CT head was also normal. He was noted to have no seizure activity on an EEG, but was noted to have a right middle lobe infiltrate. So maybe something else that's going on. Okay. Could this have been an aspiration?
Pneumonia, aspiration.
We don't know. It's still like a little unclear. We ran into a couple of other problems with this kid when he was in the ICU, was that he started becoming anuric. So he was not producing any urine.
Okay.
And so we were saying, hey, the kidneys and our liver kind of do the same thing. They kind of help filter and they help process things, but when one kind of backs up, it can cause this hepatorenal syndrome.
Yeah, they kind of play off of each other, right?
Exactly. So this kid was started on something that is a precursor to dialysis that is more commonly used in children called continuous renal replacement therapy, or CRRT.
I've heard of that. Okay.
Yeah. But even with the CRRT going and the degree of shock that his liver was in, at this point, we had to say, hey, is there something else that we can do for him? And this is where we both learned about something, which is called MARS therapy, which stands for a molecular adsorbent recirculating system, which is a type of dialysis used to treat liver failure.
Yeah, brand new to me. Never heard of it.
Yeah, so it's kind of like an ECMO for the liver, or a dialysis for the liver. And what this process is it takes the blood from the patient, it runs it through an albumin circuit. And albumin is kind of what our liver uses to kind of adsorb things. So there are certain toxins that will bind to the charge of the albumin.
Albumin's a protein.
It is a protein, yes.
It's naturally made in our body.
Correct.
Okay.
And so it acts like the sponge that binds all these toxins. And so these bound pieces of albumin are trapped into 2 different other additional adsorbers. One is charcoal, and one is an anionic exchange column, so it takes the negatively charged ions off of it. Now your albumin is free again, and it essentially gets recirculated back in, and it kind of does that whole thing.
So you're like cleaning the albumin and letting it go back and get more toxins. And
then cleaning it again.
Yeah, fascinating.
Yes, yeah. I've like never heard of this extra corporeal liver support before.
Now, I want to tell you right now, some of our listeners are trying to figure out how to put this in a van and take it to the state EMS conference to offer this,
yes.
right? Yeah,
I think this is going to become more commonplace.
Maybe even for adults? Or...
Yes, for things like severe liver failure pre-transplant. I think it's going to become even a tool for Tylenol toxicity.
Got it.
In the future. So there's a lot of use for this. It's just a question of, I think it still needs a little bit more research. But right now, it seems to be a big thing to set children up for success for future liver transplant.
Okay.
And so this kid was started on this MARS therapy as a bridge to potential liver transplant.
Got it.
It gives, like ECMO, like dialysis, it gives your organs that are being affected a chance to reset, relax, to see whether they will show some degree of returning back to normal function, or part function
Right.
to see, hey, how long can we sort of prolong this process before we need to resort to something like transplant.
If you made his liver look better, maybe the kidneys will calm down.
Exactly.
Otherwise, this kid's looking at a liver and a renal transplant
Exactly,
and a
yeah.
lot. Okay.
Yeah,
So,
so
a big
it's a
deal.
lot. Yeah.
Yeah.
The Rat Chat is sponsored by the U.S. Navy's Blue Angels. Doing awesome stuff, but now with cheese. Blue Angels.
So the next thing is let's kind of step back and say, when should we consider this diagnosis of HLH, right? It is not something that ER docs are supposed to be thinking about. It is not something that I expect pre-hospital providers to be thinking about. But your spidey sense should kind of go off for a few things. If it's a sick kid or an adult that looks septic, but just something's not quite adding up, right? Persistently high fevers, splenomegaly, unusual bleeding or bruising, altered mental status or neurologic changes. And then really what we're trying to underscore is a really sick patient with signs of multi-organ dysfunction in the setting of abnormal liver enzymes, varying blood counts, high ferritin levels. That's when we start thinking about it.
Right.
But basically, something just went from 0 to 60. And you're like, what could I be missing?
Well, and even from the pre-hospital standpoint, the thing that jumps out at me that is simple to check but is foreboding is that low glucose.
Yes.
Right. I mean, kids after, some children right after birth can have, hypoglycemia, I guess, whatever, right? Mm-hmm. But kids who are eating and have a normal diet should really never be hypoglycemic, right?
That's correct, yeah. And if they are, it could be from something like persistent vomiting, things like that, and they're not taking anything in. So that's what we worry about. It's not, whenever we see someone with gastroenteritis, it's usually not the gastroenteritis that we're worried about, right? It's the degree of dehydration and potential hypoglycemia that can come with not putting anything, not replacing any of that.
But even then, would you say even in that kid, like the glucose might be 50?
Usually they're going to have reserve. Exactly. They're not going to be less than
20 or
not
low.
Right. Correct.
Yeah,
absolutely.
That's scary.
That is really scary. And yes, that's a super simple, easy thing to check. And sometimes we forget about that additional vital sign of what that glucose is, right? How do we treat HLH? So that's the next thing. We involve a bunch of specialists. And the specialists that deal with HLH are the hematologists, really. The infectious diseases folks can kind of also help as well if we think this is an infectious etiology that's leading to HLH. They're treated with intensive critical care pediatricians in the ICU. And then occasionally rheumatology is involved if it was something like a rheumatologic patient.
Autoimmune
like
type
a lupus
triggers.
patient or something like that.
Okay, got it.
And how do we treat it? So one of the things is steroids.
Okay.
And we usually tend to think about steroids pretty early in these kids because they're in this, what we assume is this really significant septic shock stage, right?
And let's touch on that just for a second. Because our crews ask about, should we be giving steroids in the pre-hospital setting? And my answer is always kind of, we don't exactly know what we're treating yet, right? But in this case, when you give your initial steroids, you're thinking about low adrenal function. It's a big word that they've heard before, gluconeogenesis, using those glycogen stores in the body to mobilize into glucose. And that all requires some kind of steroid interaction, right?
That's correct, yeah.
Okay. But now you're talking about in the treatment phase, we're talking about long-term steroid use.
Not just that first dose, which we think about as ER docs, we think about as pre-hospital providers. Yeah, that initial steroid to kind of help that adrenal insufficiency. But this is more of a continuation of that steroid regimen, and it could be a little bit more aggressive.
Give the immune system a little
break,
a little tamp down.
Yeah.
Okay.
And then we actually treat this with chemotherapy drugs. This
Okay.
is actually the primary mainstay of treatment. And there is a new drug that was approved for HLH treatment called Gamifant.
Really?
Yeah. Huh. So this is a chemotherapy drug that suppresses immune activity. Etoposide is the other one that is a little bit more of a known chemotherapy, but it is now second line compared to Gamifant.
Because all these things do have some kind of secondary toxicities.
Correct.
And issues.
Yes.
Okay.
And then supportive care, and then treating the underlying cause if it is something either infectious, malignancy, or genetic. And if it is a genetic form,
what do you do about that?
These kids can get a full recovery with a bone marrow transplant.
Wow.
Yeah. So we essentially support these kids through their initial course. So let's go back to case 1.
Okay.
So where are we today? So this kid is now a 4-month-old. He was started on therapy with Gamifant, etoposide, and steroids.
Okay.
At the point when I checked on his chart last, he was still on day 40 plus of this treatment. And he was having a little refractory disease, but the hematology team was confident that everything was moving in the right direction. And so he was found to have this genetic component. He had this gene mutation in the perforin gene.
Okay.
So he did have this genetic variant of HLH. And the BMT team thinks once we get him stabilized, 2 to 3 weeks of organ function testing to make sure that he is ready to go, and then admission for a stem cell transplant.
That's wild.
Yeah.
This is what, I mean, I am too terrified of children to do pediatrics. But what I love about the discipline is that these kids have therapies that can, in many cases, cure them.
Yeah.
Which is baffling.
Yes, this
and
used
great.
to be a fatal disease. It used to be hard to diagnose, but this team did a great job. They resuscitated appropriately. They thought about the differential. They identified HLH quickly. They started appropriate therapy. They got the hematologist involved to talk about what's going to happen next, so that once he is in remission from this HLH little flare that he's got going on, essentially, he's going to have the chance for full, complete remission and never have to worry about this again.
That's really neat.
Yeah.
That's great. And then I do want to talk about some other conditions. So what happened to our second patient?
Yeah, let's talk about our second kid. Our second kid did not have as great of an outcome.
Okay.
Unfortunately, he was noted to have a pretty severe hepatic encephalopathy, right? That high ammonia level can definitely do things with our processing of our glucose metabolism in our brain. And then he ended up having, although I said initially he didn't have any seizures on his EEG, he started then developing seizures that were really difficult to control. He continued to be anuric despite being on CRRT, and he was found to have EBV viremia that was leading to his diagnosis of
EBV,
HLH.
Epstein-Barr virus.
Yeah.
Which in our teen population is
Mono.
mono. Exactly.
Correct.
That's the kissing disease, folks.
Yes, be careful.
Yeah.
And he was noted to have influenza B pneumonia, which is what that middle lobe infiltrate was thought to be.
That's a real double hit.
I know. Influenza, CMV. I mean, so what influenza does is it really just like weakens your immune system, which lets all these other potential things come in. So we actually see a lot of Staph aureus pneumonia in kids that have influenza to start with. And he also got secondary MSSA bacteremia from his lines.
Okay.
So he had EBV, influenza, MSSA bacteremia, which then led to this multi-organ failure, and he was no longer deemed a candidate for liver transplantation and was put on comfort care measures.
Okay. So he passed away.
He did, yeah.